Hello everyone. I'm here with an unusual case today. So this is a case of a 52-year-old lady. She had sudden onset of unresponsiveness while eating dinner. This patient was shifted to a local hospital and resuscitated there. Now in past, this patient complained of headache and occasional vomiting for 2 months. A month later, again she had headache, vomiting, ataxia, for which she was treated conservatively and discharged from the local hospital. MRI findings revealed gross dilatation of fourth ventricle with a suspicious T2 hyperintense intraventricular cyst seen with imperceptible walls measuring 5.3 into 3.2 into 4.2 centimeters. Now this cyst was hypointense on T1 weighted images. The FLAIR images revealed signal suppression without any evidence of restriction on diffusion weighted images. Moderate obstructive hydrocephalus with dilatation of both the lateral ventricles and third ventricles with ventricular index of 42% and maximum third ventricular width of 15 mm was noted. Suboccipital approach and total excision of fourth ventricular cyst was done. A shunt tube was passed from aqueduct to cisterna magna. Coming to gross examination, in lab we received these three whitish soft to cystic structures, and you can see presence of nice hair tufts and these keratinous whitish material. The histopathology was very typical. You can see this is a cyst wall lined by stratified squamous epithelium, and it contains mature skin appendages such as hair follicles and the sebaceous glands here. The lumen contains keratinous material. You can see this keratinous flakes, and the cyst wall is fibrocollagenous, shows infiltration by lymphocytes and plasma cells. Foci of calcification were also present. So we gave a diagnosis of dermoid cyst of the fourth ventricle. These are the post-operative scans. Now coming to discussion, dermoid cysts are rare clinical entities which account for 0.1 to 0.7% of all brain tumors. These manifest mostly during early adolescence, but in our case this lady was 52 years old. Coming to etiopathogenesis, these are congenital benign tumors known to evolve gradually with slow growth as a result of progressive epithelial desquamation and gland secretions within the cyst. The cyst arises from inclusion of ectodermal elements within neural tube during its closure between the third and the fifth week of embryonic development. These are most commonly located in the cisternal spaces, mainly in the CP angle and the paracella cisterns. Posterior fossa dermoid cysts are typically midline within the vermis but can also occur in the fourth ventricle. Even lateral locations in the cerebellar hemispheres have been noted in the literature. Logue and Till classified posterior fossa dermoid cysts into 4 groups depending on location, extradural or intradural, and depending on the degree of development of the dermal sinus, that is absent, partial or complete. So the extradural dermoid cyst with complete dermal sinus, intradural dermoid cyst with no dermal sinus, with an incomplete dermal sinus or with a complete dermal sinus. Clinical features are related to the mass effect, that is obstructive hydrocephalus and raised intracranial pressure. They present with headache, nausea, vomiting. Cerebellar signs such as ataxia, dysmetria, seizures, cranial nerve palsies, usually of the sixth and the seventh nerves, papilledema, bradycardia, and hypertension. Coming to imaging findings, on CT scans, they are usually hypodense uh, due to their lipid content. Calcification is frequently present and the tumor does not enhance after administration of the contrast medium, and occasionally they may mimic a hemorrhage. Coming to MRI, these are typically hypo intense on T1 weighted images, and these vary from hypo to hyper intense non-homogeneous lesions on T2 weighted images. Typically they have high signal on FLAIR images and are moderately restricted on diffusion weighted images. Now the size and the shape of the cyst may vary. These may be round, oval or bilocular and may vary from few millimeters to several centimeters in diameter. Posterior fossa dermoid cysts may be associated with other malformations such as Klippel-Feil syndrome, Dandy-Walker malformations and agenesis of corpus callosum. Our treatment is complete surgical excisions. Complications such as aseptic meningitis may occur due to dissemination of the contents of the cysts. Prognosis: no recurrence after complete surgical removal of the cyst has been reported in the literature. Extreme precaution is advised when a dermal cyst is found to penetrate the occipital region, as a connection between dermal sinus, dermoid cyst and cranial venous confluence is possible, and unexpected penetration is associated with rapid and fatal exsanguinations. Mortality and morbidity increases if there is chemical or bacterial meningitis or associated cerebellar abscesses. Thank you very much.